Good afternoon. In keeping with the ethics component of the symposium, I have no disclosures. One of the questions that you may ask is why even have a discussion of informed consent and the informed consent process in this discussion on the ethics and surgical innovation. And so in keeping with my educational component, we did a needs assessment. So if we look at some relatively recent literature coming out of the University of Virginia's Center for Bioethics, they did a study a few years back which looked at a survey of over 650 surgeons. And only 50%, actually less than 50%, identified this particular comment, that is comparing a new technique to the existing standard of care retrospectively, qualified as research. That means that 50% or more did not think that was research. In an earlier study, they looked at the authors of surgeons who reported and published on innovative surgery in the medical literature. And there were 21 of these people who fully completed the questionnaire. Only 14 identified their project as research. Only 6 of those 14 obtained IRB review. And only a third of the 21 noted the innovative nature of their procedures in the consent discussions that they had with their patients. So I would argue that there is, in fact, a need. Now, the history of informed consent really is a legal history before it was anything else. And the earliest case that I can find, or I'm aware of in the Anglo-Saxon jurisprudence, dates back to 1767. And this is an interesting case because a patient came to a physician with a broken leg, which had been treated elsewhere, and asked for a change to have the dressing changed. Without the patient's permission, the physician and his assistant refractured the leg and then placed it in a device which they thought would improve healing and straighten the leg. The patient then sued for a breach of contract in those days because they didn't really have consent, and won. They not only won, but also because the procedure which they did and the device which they used was contrary to the standard of care at the time, the physician was found guilty of negligence. A lesson. In the United States, the concept of informed consent really comes from this case of Schlondorf versus Society of New York Hospital. And in 1914, and the case of the decision was written, the opinion was written by Benjamin Cardozo, who went on to become Associate Justice of the Supreme Court, in which, in this opinion, then Judge Cardozo established this role of patient autonomy. That is, that every human being of adult years and sound mind has the right to determine what shall be done with his own body. And the surgeon who performs an operation without his consent commits assault, technically battery, for which he is liable in damages. This concept was, over the ensuing decades, was expanded by a series of case law, and the principle of patient autonomy is now firmly established in American law. Virtually all states recognize the right of the patient to receive information about their medical condition, their treatment choices, risks, possible outcomes, and prognosis, and that the failure to obtain informed consent for non-emergencies may be a civil or even a criminal offense. The informed consent process has three basic elements associated with it: disclosure, understanding, and patient decision. Disclosure is basically information dissemination that the patient has the right to have, and you see those things listed here. The question is how much information is adequate? And there are three standards that have generally been applied or have been articulated. The first is the reasonable physician rule. In other words, what would a typical surgeon, in our case, a surgeon say? That now is largely of historical interest. The second one, the reasonable patient standard, is the one that's most widely used now, and that is what would the average patient or typical patient need to know to be an informed participant in the decision. And then finally, the subjective standard, which is now argued basically in academic circles, both legal and ethical, is what's necessary for this particular patient to know and understand in order to make an informed consent. So the second part of this is understanding. It's important for the patient to comprehend the disclosed information. Educational aids and other materials may be important to aid in this, the development of this understanding. But in the end, it's the surgeon's responsibility to be sure that the patient understands the information that's been provided. And then the final component of informed consent is decisional capacity, and this is distinct from competency. Competence is a legal determination. Everyone is presumed to be competent until a court of law declares them incompetent. Decisional capacity requires the ability to understand the relevant information, to appreciate one's medical situation, to be able to communicate their choice, and to engage in rational deliberation. Decisional capacity can wax and wane and be affected by the illness. There can be religious and cultural issues or differences which may have to be dealt with and occasionally even require outside assistance from the family or clergy and others in order to deal with those. And there are problems, obviously, with the basic informed consent process. The surgeon may be a poor communicator, be uncertain themselves, unwilling to alarm patients, or be hurried or harried. The patient may be also one of the limiting factors, either because of limited capacity and intellect, inattentiveness, distraction due to various factors, including their disease, and unwillingness to listen, and so forth. However, none of these factors erase the need to enjoin the process. And it also, in the end, one must remember that a reasonable patient may refuse a recommended therapy. So we've looked at both treatment. You've got to remember that treatment, the goal of treatment, is to benefit the individual patient. The next element to look at in terms of informed consent is research. And the goal of research is not to benefit the individual patient, but to benefit society by generating generalizable knowledge. And therefore, it's largely been recognized that the research subject, the patient, needs additional protection under these circumstances. And a lot of this came out of the searing experience of the atrocities that the Nazis perpetrated before and during the Second World War. It's resulted in the Nuremberg Code, which was a legal document, and then subsequently in the Helsinki Declaration, which was developed by the World Medical Organization, which basically articulated the ethical requirements and principles to engage in human research. Shortly after that, Henry Beecher published an article in the New England Journal which demonstrated that a series of articles published in the preceding 10 years in very reputable journals by very reputable, at the time, individuals breached virtually any one of a number of those articulated principles in the Helsinki Declaration. And then out of that came the Belmont Report, which Dr. Strasberg so articulately talked about earlier. The elements the ethical elements that are embodied and have to be met in human subject research. You see listed here, basically it's a respect for persons, beneficence, and justice. The main focus for a lot of them is early on, and perhaps even now, is particularly the respect for persons, that is voluntary informed consent and the protection of vulnerable persons. Obviously, the idea is to maximize the benefits for them and to minimize harms, and also to not exploit some subsets of the population, and thus, but also make available the benefits of the research to them. Informed consent, because the patients are perceived as being vulnerable, they need more information in order to make a rational decision, hence the very lengthy and complicated, if you will, IRB mandated, if you will, consent documents. It's imperative that the consent be informed, fully, and totally voluntary. And it must be clearly articulated in the informed consent process that patients are free to refuse to participate, to refuse to continue or withdraw from the study at any time, and at no risk to them and their care. So where does that leave us? We've talked about treatment, standard treatment. We've talked about research, but what about innovation? Where does that fall in this spectrum? Well, the Society of University Surgeons a few years ago developed a position statement, and in the process of doing so, went through a process of thinking and articulating about some of the issues related to this. They defined innovation as being the modifications of existing procedures that incorporate new or unusual surgical techniques, approaches, or methods, which make them appreciably distinct from the standard of care. Not that different from what I think Dr. Strasberg mentioned earlier. They recognize that the innovations may be the result of necessity in a specific clinical situations, of trying to improve outcomes, or of testing a new idea, technique, instrument, or device. They articulated that, this group articulated that surgical innovation in itself is not problematic, and that in fact is in some ways necessary. But they did have a caveat, and that is the absence of any organized oversight or mechanism to protect patients from becoming unwitting research subjects is problematic. So, they went on to look at and try and define or subdivide surgical innovation. And they came up with three categories. One is variations, two is research, and then three is innovation. And they were actually fairly explicit about defining what each one was and what the ramifications were for the informed consent process. Variations are these minor modifications of a surgical procedure that does not have the reasonable expectation of increasing risk to the patient, in which case your standard treatment informed consent process is fine as long as it includes a complete description of the critical elements of the proposed procedure. The specific details, including minor variations, need not routinely be described and are left to the surgeon's discretion. Research, on the other hand, which we've already heard some things about, is in fact a systematic investigation, including the development, testing, and evaluation designed to develop or contribute to generalizable knowledge. In basic principle, if you intend to disseminate the information, publish it. It's research. And in that case, innovation must meet all IRB requirements, and here are the principles that are codified in the management of human subject research. Which leaves us with the last, that is innovation, which they described as being new or modified surgical procedures that differ from the current accepted local practice, the outcomes of which have not been previously described, and which may entail risk to the patient. These may be ad hoc developments, and they may be more, quote, a more systematic development, and ultimately may meet the criteria for human subject research. They did go on to say that if the procedure is not described in U.S. surgical textbooks, got to remember this is aimed at a U.S. audience, its novelty should be part of the informed consent process, even if it's common practice elsewhere in the world. The informed consent should be in the nature of full disclosure to the patient or the patient's surrogate. Before the operation, this should take place before the operation if the innovation is planned as part of the general informed consent process, and postoperatively if the innovation is unanticipated and takes place during the procedure. The other imperative is that the outcomes of this innovation need to be reviewed on an ongoing basis, and inclusion of the results in the informed consent process is now obligatory, or would be obligatory. Informed consent process should include specific discussion of the innovative aspects of the procedure. And they go on to say that any omission of such a discussion arguably involves deception. Whoops. And violates the patient's autonomy-based rights to submit to patient care. So, in summary, informed consent is a process, it's not an event. It requires a dialogue, it's dynamic. Relationships with patients, at least that's been my experience, are usually strengthened by the ongoing discussion. Mutual respect and trust is critical. Truthfulness, transparency, integrity, and patience are essential ingredients for engaging in the informed consent process. And when engaged in innovation, disclose extensively and engage the IRB early and liberally. Thank you.